Hey everybody, it's Jessica DeMassa with WTF Health. What's the future of health? I am talking to the who's who of health tech and healthcare innovation. And today I'm checking in with Micky Tripathi. He is the National Coordinator for Health IT at the U.S. Department of Health and Human Services. And we are going to get an update on all things ONC is working on to help create an open atmosphere for us to grow our health tech companies. So Micky, it's great to have you here.
Thanks, Jessica. Really happy to be here.
I am so excited to talk to you because I think, one of the things about a lot of these, the policies that you're working on, the frameworks that you're setting up, the standards, it's like for some of us who are not, developer background, this goes over our head. And so we're going to have more of like a high level conversation about what this means to the rest of us who are in health innovation. So we can help our developer friends along and we can help ONC and support some of the things that you're working on in order to, improve the exchange of health information. And so one of the things I wanted to dial in on right off the bat is this health affairs article I read from a few days ago. And you're talking about the fact that this year is going to be a transformative year. And so, to quote you, this year will be the transformative year. It will take the decade-long investment in health information technology to the next level. And so I want to understand, Micky, what is it about this year? What's going to happen that we need to be aware of that really is going to take that decades-long investment to where it needs to go?
Oh my God, did I really say that?
Yes. Busted.
I guess it must be true then. So
if it's not, this interview is going to take a very interesting turn.
Yeah, no, I really do think that it's that this is going to be a transformative year, the reason I think that is, as sort of in that sentence you quoted, I mean, we spent like roughly 10 years now, and over $40 billion of public investment and an equal amount on the private side, and a ton of sweat equity on the part of providers and health IT developers and other stakeholders to lay this electronic foundation. And it's taken a long time, and it's been a ton of hard work. But now here we are, like the dust is settling on this foundation, and now we can start to think about what is it we want to build on top of that. So a part of it is, just sort of the work that has been done and accomplished, and now here we are at the end of it. And what intersects with that is the 21st Century Cures Act and a number of requirements that come from the 21st Century Cures Act that basically direct all of us to start building on top of that foundation, to sort of recognize that you've got this digital foundation now that we can start to think about the healthcare delivery system as being digitally native, which it really wasn't before. I mean, and I'm not saying that it is, that we've flipped a switch and now we're digitally native and there's no more paper and there's no more faxes, because we know that those are there and those exist, and the healthcare delivery system is still based on paper, bricks and mortar, kinds of principles. But from this point going forward, we know that electronic health records are in the vast majority of provider organizations, acute hospitals, healthcare, ambulatory providers, and all of that is becoming more and more digital. And so we can now start to think, how do we redraw the way healthcare delivery is structured, and how do we sort of remap that to a world that's based on bits and bytes and not on paper, bricks and mortar? And I think that that your audience here are the innovators, right? They're the ones who are trying to redraw that map. So really look forward to ongoing engagement.
I mean, so you're preaching to the choir here, obviously, but it's like what I want to make sure that we understand on our side of things is, is some of the finer points in terms of how this is going to impact us and really what's changing, because a lot of these innovators don't have this 10-year perspective of what's happened and all that's gone into laying this framework and what it really means in order to they're kind of coming in like, all right, great, let's build on top of it. And I'm wondering, from your perspective, if you could share, I mean, I know where we're at right now, but give us like a little bit of a backgrounder on this, like a couple minutes, just like talk to me about this change, because you've been involved in this for a really long time. I mean, from back in the days in your role in Massachusetts, setting up health information exchange there. I mean, like, so give me a sense of like, let's talk through the pain and suffering that went into this, Micky.
Sure. So, when ONC was first founded in 2004, and that was kind of when I got involved in health IT, we were looking out at a landscape that was 10% of providers had electronic health records. And that included, my sister-in-law's Access database, which I swear is really awesome. It's like the best EHR, or Microsoft Word with macros. I mean, I don't even know if Microsoft Word had macros back then, but but that was included in that 10%. And back then, and I know a lot of because this is the innovation community. many of the people who are listening to this actually don't remember 2004. Back in 2004, they were in high school or something.
Right.
But there was a world back then that felt really barren. I mean, we're all looking out and saying, how the heck are we going to get the most complex part of our economy to adopt electronic health records, knowing that there's a ton of value to doing that, and seeing that, it was happening in banking, it was happening in the retail industry, it was happening in airlines, but how are we going to get the healthcare sector to move? And we're looking at other industrialized countries and somewhat envious of what was going on in Europe, for example, and in Australia and other countries where they had jumped ahead with electronic health records. I mean, they had really leaped ahead. And the part it was related to the structure of their healthcare delivery system. That in the UK, for example, they are the payer, they are the provider, so they get all of the economics all line up where it makes sense for them to invest in that network because the returns will all flow back. In the US, we have this problem where the providers, it's so fragmented, right? The healthcare delivery system is so fragmented and the economics are so complex that you have the providers who are basically saying, I'm not going to invest in electronic health records because you're asking me to pay all the costs and everyone else is getting the benefits. I actually don't get any of the benefits. I have no pricing power. Like if I was in another market, I have pricing power, right? I could pass the cost of that onto my customers. I could amortize it over a number of years, increase my prices, get my return on investment, whatever payback makes sense to me. I could do all that. But right now, a healthcare payer, Medicare, isn't going to pay me any more for implementing electronic health records. So all the benefits have to come through efficiency. And how am I going to get that efficiency to justify the $35,000, $40,000 per provider that an EHR system would cost? So we kind of had this stalemate, and the payers on the other side were like, well, it's all fragmented. Any particular doctor, maybe 10% of their patients are mine, but 90% are others. So why would I help them? If I'm investing in my competitor's ability to have efficiency. So why would I do that? So anyway, we had this big stalemate for a number of years. So that's kind of what it looked like. It was a barren field. And then high tech came along, which is basically the way I think about this is, pure, like in business terms, was Medicare and Medicaid, the only, the only healthcare entities that are big in every market. If you look at everything else, every other payer, every other provider, they may be big in local markets, but they're not big in every market. Medicare and Medicaid are big in every market. And so they basically were looking at it and saying, I've got a supply chain issue here. I need my supply chain, which is the providers who provide the care that I pay for. I meaning all of us, right, as taxpayers, that we pay for. And I need to get them to invest in technology. But right now I've got the stalemate. So why don't I, sort of subsidize that? Why don't I actually provide them incentives? And, and I think, probably lots of the people who are listening to this are very familiar in other industries. Toyota, General Motors, Walmart does this every single day, right? They work with their supply chain and they say, tell you what, we will split the cost of that RFID technology that, that I want you to implement, but you feel like, it doesn't make any sense to you. So why would you do it? In the same way, this is basically Medicare and Medicaid looking out and saying, we need our supply chain to, to upgrade. We understand that we get a lot of benefits, so we're happy to split the cost. So that was, sort of the meaningful use program, right? That's how the meaningful use program came into effect. And we had the ability then to say, we can provide a lot of money, $40 billion, to get the, our supply chain to, to basically upgrade and implement these technologies. So, that was sort of the hard work that was needed to be done, the alignment of the economic incentives to get us to the point where we are now.
And that took 10 years, and like here we are, right? And it's like, and so like where we're at now, and this was another thing that I was looking through in that piece you wrote for Health Affairs. It's like there's like the three core things that we're talking about now, and I'm wondering if we can kind of pick your brain on some of these too, because it seems like the things that are happening, that building on top of that platform that you guys have spent so long creating for us. Information blocking, API standardization, and then TEFCA, and I'm going to mess this up, trusted exchange framework and common agreement. And so I want to understand, I had to cheat. I looked at my notes, but I want to make sure that we understand as health tech innovators, what that means, both in terms of not only the technology side of things, but also the business side of things, as we're helping kind of support and further align those economic incentives to try to digitize and bring more technology into healthcare to help, do all the things better, whether it's using AI to help, better identify patients for like earlier in their needs for care, or, smooth out payments on the back end, like that whole gamut. So let's start with information blocking, because I do feel like this has been This has been a topic of conversation for, since the rule went into place, then as things got delayed through COVID. So can you give us an update on where we're at now with the information blocking rules? What should we expect this year?
Yeah, sure. And all three of those things you named, APIs, information blocking policy, and TEFCA all fit together. I mean, they all fit together, even though they are separate things that were named in the 21st Century Cures Act that was implemented. I mean, the 21st Century Cures Act was passed in 2016. It was signed by President Obama and wasn't implemented.
Feels like a lifetime ago, Micky.
Until starting 14 months ago, until we came into office, it wasn't implemented. So, we really need to get moving on this. And so that's a part of why I think, 2022 is going to be so important, is we're implementing these things now. We're basically saying all that great stuff that was in 21st Century Cures Act that had really strong bipartisan support, we need to put it in place because, there's a tremendous amount of value for that. So, let's take those.
Yeah, let's do.
So information blocking, to your point, one of the things that, is a part of the lessons that we've learned over a number of years is we implemented electronic health records, as I said. And one of the things that we saw, because a lot of people say, boy, what a failure. You guys should have built in interoperability from the first day. Well, one of the things that we found is that in turning arguably the most complex sector of our economy, which, certainly back in 2010, and it still is kind of like that today, is really like a craft industry. I mean, if you think about small provider practices and how much they do in terms of care, those are like small, businesses. They're not, sort of Mayo Clinic. That is not the image that people should have in their minds when they're thinking about the healthcare delivery system. So there was a lot of challenge to say, we just need to get them to move from paper to electronic and land safely, meaning they've moved to electronic documentation and they're actually getting paid. And I know people, always say, oh, electronic health records are just fancy billing systems. Well, people actually need to get paid. I mean, if people aren't getting paid, my organization back then, a nonprofit, we worked on, elbow to elbow with providers implementing electronic health records. And I can, tell you with assuredness that the minute the revenue cycle stopped for a provider was the minute they said, I'm not doing this stuff anymore. I am going right back to paper because I'm not getting paid. So, we needed to focus on that. We needed to say that's a part of landing safely. You do electronic documentation and you're getting paid. So we spent a lot of time doing that. And now we sort of say, and by design, we said, we'll hold off on interoperability. And in some ways I say, thank God we did that. Because if you think about, if we had tried to do interoperability back in 2012, 2013, it would have been like trying to force, AOL on everyone or CompuServe, right? We would have basically said, oh, well, here is the way we think about the internet today. AOL, awesome service.
Perfect.
CompuServe, Prodigy, for those who remember all of these, these old services, right? Because we didn't really know. I mean, we weren't talking about APIs then. We weren't talking about RESTful APIs. Fire was, not even existent back then.
It's not even a Spark.
Right, exactly. And so in a way, you sort of look ahead and say, look, we're going to be doing this for 5, 7, 10 years, it turned out. We better, sort of phase this and acknowledge that there's going to be a lot of technology developments, and let's keep the options open to how we're going to do this. And that's exactly sort of how it played out. But we laid that foundation. Now here we are. So 21st Century Cures Act comes and says, great, you guys have laid this foundation. Awesome. First thing is we've got some behavioral problems. And that was the perception of the Congress, and said, and the behavioral problems are that people don't have an instinct to share the information. They have an instinct to not share the information. And we could argue about whether is that hoarding information for competitive purposes, or my experience actually is that it's more about people not putting it high enough on the priority list. Because if because it actually is real work. It's real work to do interoperability. It isn't just, oh, let me just flip the switch and now everything's interoperable. It's like a lot of workflow change. There's a lot of configuration, some technology that you actually have to implement to make sure that it's, sort of interoperable with these other systems. So it's real work. And any CIO, any small practice, they've got 18 things on their priority list. And every year it's like, well, interoperability, yeah, that'd be great. I still get it via faxing and I got to do all these other things. Basically, the 21st Century Cures Act with information blocking is saying, you know what? You got to make that a priority. You got to make that a priority. HIPAA says that you are permitted to share the information, but you're not required to. 21st Century Cures Act comes along and says, you know what, you're actually required to. So move it up your priority list, make sure you're making that information available. So this year, what that means is on April 5th of last year, again, 21st Century Cures Act passed in 2016, didn't go into effect. On April 5th, we said, this is going into effect. Everyone is required to do this from this point going forward. And what that means is they're required to make available information to patients and to other parties through means that are without special effort, is the actual sort of term of art. And so what that means now, what we've seen is we have a complaint portal. People can file complaints where they believe that information blocking has occurred. And we publish this data. It's on our website, and we're going to continue to publish the data on a monthly basis. We've received over 1 complaint per day on average since April 5th. The vast majority of those are patients complaining that providers are not providing them access to their information. So already, I think you're starting to see, it's having some impact on the market. Yeah. Now, arguably, and certainly maybe there's way more out there, and 300 is a really small number over that period of time, but hopefully awareness will grow, and and we'll see that. But I think that's the first step to sort of saying we got some visibility now into what's happening, and now we have a process for identifying where these things might be occurring, and then and then we'll go through enforcement and all of that. So that's the first piece, which is information blocking. Let me pause and see if you have any questions.
Yeah, I mean, I think my big question on information blocking is like, given what about uptake of health policy in this arena, what are your expectations? I mean, in terms of how long this is going to take where it's actually working. I mean, like 10 years to go from 10% digitized EMR to 90% of providers having an EMR. Like, if you're thinking about this, like Micky, like give us a reasonable expectation in terms of like, what's the pace of this really going to be? Yeah,
I mean, my guess is that it's not a one-year thing. So as much as I'd like to think, as a regulator now, 14 months in place, I took the job thinking, oh man, I'm gonna have all this power. I wave my wand and everyone does what I say.
That's not how it works.
Yeah. The reality is, our thing went into effect on April 5th. Does that mean that on April 6th, everyone changed their behavior? We know the answer to that is no, right? Yeah. But I do think that, over the next 2 to 3 years, we should start seeing significant change in the industry because people are really starting to incorporate it, I think, in their thinking. I mean, we've talked to lots of provider organizations who compliant, from a compliance perspective, they're looking at it and saying, this is a regulation. It's just like HIPAA. It's just like other regulations. And we need to be in compliance because, OIG actually has enforcement authority over this, and they can, administer fines on 2 of the 3 actors. So, so I think that we're going to start to see that over the next couple of years, that there will be substantial change in people's attitudes toward this, in part because of the compliance part. And I think the complaint process, and I see a really important role that the government plays is providing information back to the market, which is why it was really important to me that we provide the complaint data back to the market to say, hey, here's what's going on, so now you market, you can start to understand this. And hopefully that was a message to providers that, hey, we got some cleaning up to do here. These complaints are actually coming in, so we probably, ought to pay more attention to that. The other reason I think over the next couple of years we'll start to see it is, and this is I think where the audience here can play a critical role, is in the strategic opportunity of it. Because you think about, yes, the information blocking role, it imposes a burden on you if you're a provider or a vendor to make information available. But the other side of that, and when I was at HIMSS, I talked to an EHR vendor who their first message to me was, we see this as strategic opportunity. We haven't been able to access information from other systems. And now we're starting to say, hey, if we are able to more easily access that information, think about everything that we can do from a value perspective, from a benefit perspective, and think about the costs that we're not going to have to bear because it'll be easier to get that information. So I think that's going to be the other side of it, that people start to move from compliance to seeing the opportunity and saying there is business value here to be driven. And that's where, again, where this audience
absolutely
plays a huge role, pounding at the castle doors saying, hey, if you get access to that information like 21st Century Cures Act, here is the app that is going to solve a couple of these problems that you're facing every single day.
Between your castle and your magic wand, you have a very fantastic magical view.
I know, it's like a Harry Potter,
the magic of health IT with Micky Tripathi. All right, this is, I think, the perfect segue to the API conversation then. So talk to me about the API standardization. And I'm sure my audience is probably, pretty up to speed on this, but just high level us the same way you did just here. I mean, I like to hear about it in both ways, because I do think that it helps the rest of us who are more on the business or strategic side of health tech understand what's going on so we can support, our folks who are developing. So talk to me about the API standardization, how this fits into this puzzle.
Sure, absolutely. So I think, as most of your audience probably knows, even if they're not technical, APIs kind of drive the internet now. It is the modern internet convention for making information accessible, very lightweight, very common convention and common pattern, and it's what allows us to pick up our phone and do our banking, send money to our kids via Venmo, order Uber Eats, do banking, all with the click of a few buttons on a very lightweight app. And healthcare has kind of lagged in the adoption of sort of that pattern. And so what we want to do, and again, this is coming from the 21st Century Cures Act, which said that information should be available through an API. It specifically said API, which might surprise people that, wow, in a statute, it actually said API. Well, it did say API. It didn't say FHIR, but it said an API. And it said it should be accessible without special effort. Those are like the key terms. In the same way that meaningful use is now burned in our brains, without special effort is now burned in our brains.
I'm going to get a T-shirt without special effort.
Right, exactly, without special effort. But, yeah, that's a great idea, actually.
Thanks. Yeah, ONC, where are you at with that?
So we took that and said, we believe that the way to accomplish without special effort is for the industry to adopt a standard, open industry standard API, so that regardless of which EHR vendor, sort of that provider uses, I can take my app, I can build my app and know that it's scalable across all those different environments. Right now, you have the problem that, you got a whole bunch of proprietary apps. No one is required that the APIs be standard. Now we're saying this should be a common level playing field, so that if I'm a developer, it doesn't matter whether it's Epic, Cerner, eClinicalWorks, Athena Health, CSPI or Evident, whatever it is, I know that the economics now are going to work. I can build that app and it's going to work across that ecosystem. So that's what we've been pushing really hard. And as we know, open architecture ecosystems are what help to drive value, and you start to be able to create value on top of that. And so that's, from our perspective, is the fundamental goal here, is to have an open API platform or sort of ecosystem that people can then build on top of it, and they can form whatever kinds of business models sort of make sense on top of that, without our having to dictate, oh, this is what you should develop, because we don't want to do that. We just want to say it's open architecture. It means based on open industry standards and systems that assume that they are going to interact with each other, right? If you think of the way that Expedia and Canoe and Kayak, work today, and Kayak work today, right? They don't store the data. Their business model is based on the assumption that they are going to be able to, on demand, use APIs in the background to bring the information together for when Jessica has to go back to Florida and wants to, figure out which flight is going to be the cheapest. And so that's what we want, right? And that's all just based on open APIs in the background. That's what we want, sort of healthcare to be able to get to. And that's what the FHIR API requirement is about. And EHR vendors are required to make that available to their customers by the end of this calendar year.
Okay, that was going to be my question. I'm like, where is this a flip switcher kind of move here, Micky, or is this going to be one of those long tail where everybody's got to switch over? And where's that? So the requirement is by the end of the year, but give us a sense of timing on that.
Yeah, I mean, so we've done, what we can through regulation. I mean, one of the things that, that is really important to me, from a regulatory perspective is, how do you figure, I think regulation is really important in healthcare because the industry is so fragmented. So otherwise it doesn't move in coordination, and that makes it really hard for developers and others to really build scalable models and really build business models. So how do you get enough regulation, but not too much? So we keep creeping, more and more into it as we learn lessons. One of the lessons we learned from the past is that when we said, oh, this has to be in place by this date, is that you had a lot of developers who would say, okay, well, we have closed the code at 11:59 p.m. on the day that it's required, and now it's going to take 2 years for us to make it available to our install base. We learned some lessons, and so in this regulation, what it says is that every EHR vendor is required to make it available to their customers by the end of this calendar year. So that means it's not only in GA, but you actually have given the opportunity for the provider to actually get that upgrade before the end of this calendar year. So I actually think it's going to happen on a much faster time frame. Now, one of the things is we can't require that the providers do that upgrade. I think that's one of the, sorry, I got my dog here in the background. I like it.
That's okay. No worries.
Doing things that she shouldn't be doing. I'll allow her for a couple more minutes. So anyway, so that's the requirement. Again, it's not going to have, we have high confidence that most of the vendors will have that in place before the end of this calendar year.
Okay.
And if you're a developer and you're finding that your provider is saying, oh, well, I don't have that version of Fire implemented. I think that's the opportunity for the developer to push the provider and say, your vendor was supposed to have provided to you by the end of this calendar year, go check, do that upgrade, because now I can sell my product to you, or you can take advantage of the benefits that my product has, because, through that Fire API.
That's excellent. Okay, good. So helping everybody kind of become interoperable in that way in terms of being able to integrate some of these new technologies. That's fantastic. All right, last thing then in this 3-point ONC plan for the year.
TEFCA.
Talk to me about TEFCA, because this is the one I'm going to be very honest with you, and this is one I have the hardest time understanding. So
get it. All right, I'm going to make this easy.
Okay, good.
This really easy. So the first thing I'm going to make easy is, TEFCA, the Trusted Exchange Framework and Common Agreement. I like to think, and we like to think that TEFCA is just going to become TEFCA, like HBO, right? And,
okay.
I asked my kids, the other day, do you guys know what HBO stands for? And they're like, it stands for HBO. I was like, no, it stands for Home Box Office. And they're like, what the heck does that mean? What's a home box office? So that's what we want TEFCA to be too as well. But we explained, it's a trusted exchange framework and common agreement. It's like, I don't know what the heck that means, but it's TEFCA. It's network interoperability. It's nationwide network interoperability. Just call it TEFCA.
Okay.
So what is the idea of TEFCA? Imagine a world where AT&T and Verizon, as wireless carriers, great nationwide networks, overlapping geographies, but they're not connected to each other. So if you and I wanted to talk to each other, Jessica, I would have to know, I'm on AT&T. Are you on AT&T? No. Darn, we can't talk to each other. Or it's limited functionality. Like with you, it's like, well, I could text with you. I can do a voice call with someone who's on T-Mobile, but we don't have uniformity. And each one is like this weird pairwise, sort of negotiation that happens between the carriers in the background. And there's no consistency across them. That's a little bit of the world that we live in today. We do have interoperability at the network level that people should realize. The private sector has actually accomplished a tremendous amount that people don't realize actually has happened through Care Equality, Commonwealth, the eHealth Exchange, a number of state HIEs. But they do a lot, like Care Equality alone, just to give people a point of reference to another industry. The SWIFT network, that by now everyone knows what the SWIFT network is, right? A month and a half ago, no one knew what SWIFT was, unless you were in banking. Now, unfortunately, we all know for very bad reasons. But the SWIFT banking network does something like 40 million transactions a day. I was reading, it was a New York Times article, and I was like, oh, 40 million transactions a day. That's interesting. Yeah. People always say, why can't healthcare be like financial services? And I thought, well, what does Care Equality do every day? Because I know they do millions and millions. Well, the number from Care Equality is they do 50 million a day. Whoa. 50 million transactions a day of exchange, and about 10 million of those, so 20% of those are actual payload, which is the actual medical record. And then the rest are the search for a patient, confirmation that I have the patient, can I have the record? Yes, have the record. So that's what that adds up to 50 million. Wow. But that's actually the more apples to apples comparison, because SWIFT is a messaging platform. So it does messaging across banks. So it is like the apples to apples is like, it's roughly equal. Just Care Equality is roughly equal to what SWIFT does on a global basis every single day. So people don't know that, right? That exists in the background. I can tell by your face that you're surprised.
Yeah, no, I'm shocked at that. And I think to myself, and that's just one. Like there's
right, and that's just Care Equality. Yeah, and if you think about what's happening within Commonwealth, that's another 10 million that you add on top of that. What's happening just within the Health Exchange, not going across. That's another, I don't know how many, 10 million, 20 million, whatever.
Yeah, I mean, you extrapolate that out. I mean, that's like unbelievable.
Right, exactly. But they're not perfectly connected. And they also they haven't opened up to the broader use cases that they want. So that's the first analogy that I want to draw is this is like connecting up AT&T and Verizon and T-Mobile and saying, you know what, let's also just all have a common legal structure, common technical specifications, and common expectations. So if you're a Verizon user, you know that you can do this basic dial tone search. You can pick up the phone and call someone who's on T-Mobile, and you don't need to care about it. You don't need to care about which network they're on, right? I have no idea what cell phone network you're on, but I know I can call you. I know I can text you. Right, so that's the first thing that TEFCA is going to accomplish is that. The second thing that that I think is also is really important is opening up access to other types of use cases. So right now, public health doesn't participate in those networks. So imagine, we have 50 million transactions per day, in clinical systems. We're in a pandemic, and public health agencies are not allowed to access that information.
That's crazy.
It's like totally crazy, right? And why is that? Well, it's hard for the private sector to wrangle with these complex regulatory issues that's our public health system, right? It's 64 different jurisdictions, really complex public, so I don't blame the private sector networks for sort of stalling a little bit on getting the public health use case up and running, because it's really hard. So that's where TEFCA, with the federal government presence, we're working directly with the CDC, engaging jurisdictions to say, how do we actually figure out some of this stuff? How do we start to figure out, the reconciliation of all these different jurisdictional laws and, and data models, and say, can we all just agree to a common way of doing this? And then you can participate in these networks. And then you don't have to spend all your time wrangling fax data and typing it into Excel spreadsheets. And you can spend more time actually doing public health activities, which every single public health agency wants to do, right? They hate wrangling data. So that's the other piece. And then payers and individuals, also the ability for them to access the network directly so that they're not having to go through this cumbersome side, things. And I think that for the developer community, that's this audience, thinking about all the models that now you can, sort of build based on, with payer presence, accountable care, value-based purchasing. You start to think about, how do I get apps that can help to serve that, sort of the value enhancing kinds of business models that get right into the revenue cycle, and the more end-to-end clinical to administrative, with an expectation that I've got a network backbone that's going to support that. I don't have to build custom interfaces anymore. So that's a huge part of it. The last thing I'll just add here, Jessica, is, to me, the way to, think about TEFCA and the FHIR APIs and how do those work together is think about, your banking app.
Okay.
So right now, you use Venmo, or you use PayPal, or you use, your banking
all
app.
of the above.
Right? And so at any given point in time, I can get onto my app and I know what my bank account, is up to date. I can make a deposit, I can withdraw money, I can, do whatever I want on that app. But there is a backbone that makes sure that that information is up to date, right? That when I actually do the Venmo transaction, that, in basically real time, Venmo actually takes the money out of my account and puts it into your account. And there's a backbone infrastructure that does that.
For that.
And that's what TEFCA is. So if you think about the FHIR APIs, are about how do I access it as a user using the app, and TEFCA is about how do I make sure I've got a high volume, highly reliable backbone infrastructure to make sure that records are where they should be whenever any provider or patient wants to access them through an API.
This is like the ultimate interoperability play.
There we go.
Right?
And 2022, right? TEFCA went into place January 18th. FHIR APIs required this year. Information blocking really kicking into effect this year. All those pieces come together. And that's why I say 2022 is going to be a transformative year. Just like with anything, it's not going to, we're in it, so it's not going to feel transformative, but I'm really confident that 4 or 5 years from now, we're going to look back and say, wow, 2022 is when things started to get to the next level.
Really change. So, okay, so then leave us with this. So these things happening this year gets you very optimistic about what's going to happen moving forward. So talk to me about what ONC is looking at next then in terms of 23, 24, what is on your, beyond the implementation of these things and making sure that they get put in place correctly, what is the next big thing as you see it, that the carrot that's dangling on the end of the stick here? I want to know what your thoughts are on that.
Yeah. So I think, it's basically moving through the value chain, because we basically are helping to push the industry through the value chain, but we also follow the industry through the value chain. Right? So we basically say, all right, we got electronic health records. Now we get interoperability, and we get APIs, and we get TEFCA and all of that great stuff. So, certainly a big part of this is going to be making sure that, that we have common implementation of this, and that everyone is just moving forward with this, with basically open architecture health IT ecosystem. The next set of things is, now let's think about, use. And are there things that we need to do with respect to the use of that information that make sure that we continue to have a level playing field, and importantly, that it addresses some of the issues that are related to healthcare disparities, health equity types of issues, so that we are sure that, the technologies that we're putting in place are actually a part of the solution and don't contribute to the problem that we know exists today. So a number of those things that we're starting to focus on, data quality, right? Data quality is the bane of everyone's existence. And I'm sure, again, most of the audience are like, the data I get from different EHRs, oh my God, it's really hard to make use of it. And so that's something that we're starting to look at is, what are the things that we can do and help motivate greater consistency in data quality, like the US CDI, our US core data for interoperability, which is a set of data standards that we require everyone to support, for example. So how do we have better adoption of that and better monitoring and enforcement of that? Algorithms, as we start to think about algorithms, EHRs are increasingly the source of the data that drives algorithms and the vehicle that inserts algorithmic results into clinical workflows and administrative workflows, where people are actually making decisions based on that, based on what is coming to them through the EHR. So we're starting to look at that as well as we think about use, and are there, sort of guardrails we might want to think about, from a societal perspective as we think about the use of that. And then obviously, there are lots of issues related to privacy. As more and more information gets into your hands, one of the things you may not be aware of is that the minute you downloaded your record onto your phone is the minute that it's not protected by HIPAA anymore. And
Okay.
most people are actually shocked to know that.
Yeah, I actually did
I was like,
know that.
well, wait a minute. I thought HIPAA protected medical record information. It's like, well, it protects it when it's in the hands of certain organizations, like a health insurer, like a healthcare provider. But interestingly, when it's in the hands of the patient, HIPAA no longer applies.
Interesting.
And your data is just as vulnerable as any other information that you might put on Facebook or anything else, from a legal perspective. So we're starting to, sort of think more about, geez, how do we do more education and outreach to patients so that they can benefit from all that I think this open health IT ecosystem is going to offer to them, but they also go in with their eyes wide open about what are the corresponding risks that might be, sort of a part of that, and how do I do everything I can to protect myself so I get the benefits and don't pay, sort of the unintended costs of, of what might be sort of a horrible privacy issue, for example.
Last question for you, kind of just springboarding off of that. I'm curious because okay, so we in health tech have had a great couple of years, in terms of investment into our space, interest into our space, adoption among both payers and providers, and integration there. I'm curious on your opinion on the health tech community writ large here. I mean, you've talked a lot about what payers are doing, what providers are doing. Your organization, ONC, is helping enable an environment where we can all work together, and these health tech companies can come in and do some of these more, agile type things in terms of helping make healthcare look and feel like a lot of the other technology that we have access to. I mean, to draw on your example of banking, for making that more convenient, making that something that is a little bit more democratized. So I'd love to hear the concern that you might have on this growing well-funded crowd of health tech companies, and then also if you could end on a high note with the opportunity that you see for us, or the thing that makes you really excited about the fact that we're seeing more tech companies come into the fray here in terms of healthcare.
Yeah. First off, I think to the extent that there are concerns, it's related from my perspective, it's related almost entirely to the privacy issues, where we've got the technology that has leapt ahead of the privacy issues, that has leapt ahead of privacy policy. So I would just encourage everyone who's listening, if you're if you're a health IT developer, the law may not require that you have special protections for medical record information once it's in the hands of the patients. But I would just, urge all of you, plead with all of you to actually put into place responsible policies for the access to that information, for the use of that information, and just making sure that the patient that understands what you're doing with that information, and allow them to be a part of the process. Allow them to provide the consent for you to do, take the data, de-identify it, and and sell it to pharma if that's your business model. We're not objecting to that business model. Just allow the patient to participate in that decision, please. Yeah. And certainly with identified information. I think so. That's my biggest concern area.
Sure,
and part of that concern is actually that a number of people coming in from other industries. So I think that, a big part of FHIR and APIs to me has been fantastic, is that people from other industries are jumping into healthcare. They wouldn't before because we were doing this, XML based, 1980s standards that, I was like, I'm not
macro enabled Microsoft
yeah,
Access
yeah,
documents.
right. A 1,000-page implementation guide for a CCD, it's like, I don't want to do that.
I'm not doing this.
With FHIR APIs, we're seeing people jump in from other industries saying, I understand RESTful APIs and OAuth, perfect. So that's great. The challenge or the concern I have is that a lot of them don't actually appreciate the privacy issues that are really specific to healthcare and how important that is. So that's sort of the concern. The opportunity is far outweighs the concern from my perspective, because the benefits for patients and to others is huge. And I heard from Rock Health the other day that that investment in health tech is something like 30 million a year.
30 billion with a B.
30 billion a year, right? I'm sorry, 30 billion a year. And what I was describing before, we spent 40 billion over a decade to get EHRs in place, and now we're saying 30 billion a year, in large part to build on top of what those EHRs are going to do. So that's fantastic, right? That just speaks to the opportunity here, and and from our perspective, being able to create an open architecture IT ecosystem that allows those investments to sort of do whatever they want to do appropriately, obviously, to be able to create business value is what we're pushing toward. I mean, I feel like we'll have succeeded if businesses sort of feel like I've got the opportunity now to have running room and to deliver value to patients, providers, and other healthcare stakeholders without the technology being a barrier to it.
All right, awesome. Well, Micky Tripathi wielding his magic wand over there at ONC. We love to catch up with you. You'll have to stop back because I think it's really important for us to understand what's happening in that macro environment in terms of the standards and the policies and the things that you're putting in place, that we just need to understand how it all works together, and from both the technology side and also from the business side. So thank you so much for walking through all of that with me. I really appreciate it.
Absolutely. Thank you. And, we'd love to talk to developers. So please reach out anytime. We have an innovation group, and we spend a lot of time with the innovation community. Love to make that bigger.
Good. Guys, jump on this. All right, Micky, thank you again. It's a pleasure to speak with you. We'll talk to you again soon. Keep in touch, okay?
Okay, great. Thanks, Jessica.
No problem. That was Micky Tripathi, everybody. He's the National Coordinator for Health IT, inviting you to, participate in what ONC has got going on. So check out their website over there. And while you're on the internet, head on over to my website. It is youtube.com/WTF Health. You'll find more interviews there with the people who are changing healthcare. And I'm also a podcast, so find me on find me on Spotify or iTunes. Just search WTF Health. We'll talk to you guys real soon. I'm Jessica DeMassa. Thanks for joining us.